Dr. Kumara, I think we can start.
Still mute.
So, good morning, everyone, all the doctors and the participants. Nice to meet you today, this morning, in this webinar, ASNA Neurology Talk. Let me introduce myself. My name is Kumaratini. I'm from Indonesia, and I will be hosting this webinar for the next 1 hour. In this webinar, we will be having one speaker from Indonesia, Dr. Firdausani. And he will be giving his talking a very interesting topic on recurrent hemorrhagic stroke, neurointerventional approach. So, a brief introduction about Dr. Sani. He is a neurologist and also neurointerventionist, a vascular interventionist from Dr. Sutomo Hospital in Surabaya, and then also a lecturer in Erlangga University. He's also the head of Indonesian Neurology Association Chapter Surabaya. And the last but not least, he's the head of Indonesian Neurointervention study group. So thank you, Dr. Sani, for being here with us despite your busy schedule. So you have about 30 up to 40 minutes talk, so take your time. And then we will continue with questions from the audience. So the participants can ask questions by write down your questions on the image with the right button of your screen with everyone, or you can ask a question directly. So without further ado, Dr. Ahmad Firdausani, you may start your presentation, and then time is yours.
Thank you, Dr. Kumaratini. Good morning, everyone. Thank you for the ASNA, Professor Lim, Dr. Paulus, and having me here to present my topic. I would like to share my screen. So, Dr. Kumara, it's already seen?
Yes, I can see it.
Okay. Thank you again. I would like to present about the recurrent hemorrhagic stroke neurointerventional approach. So I would like to share our experience in Indonesia, especially in our neurointerventional study group regarding this topic. So recurrent hemorrhagic stroke is frequently we meet in our daily practice. So as we know that stroke hemorrhagic is around 12% of stroke, but with a high morbidity and mortality compared with ischemic stroke. So we have two types, ICH and SEH. SEH is only 2-3% of hemorrhagic stroke, but with higher morbidity and mortality in all of type of stroke. And hemorrhagic stroke also in some type is there is IVH and SDH also. We found some cases with spontaneous subdural hematoma. And the most important one is to determine the etiology of the SEH and ICH. In case of the recurrent bleeding, we have some missing etiology, and or we stop only to treat acutely but not looking for the etiology. In Indonesian stroke registry, hemorrhagic stroke is 2.9%, but it is hospital based. In population base, it is around 12 to 13%. So this series in our hospital in 2014, we have 467 hemorrhagic stroke. SEH is around 15% and ICH is 18%, 85%. But if you see that mortality is higher in SEH than in ICH, and this is actually also happen in global community. But when we try to decrease this mortality and we evaluate more in 2013 and July 2018, the mortality has decreased to 51%, and then in the last hour series with 30 and 360 SEH, and the mortality again decreased to 45%. So we have subtype of ICH. Not all ICH is similar. We have subcortical like this. We have also cortical and subcortical. We have pure IVH. We have IVH and ICH. We have only cortical in old person. So we have a subtype. Not all intracerebral hemorrhage is similar. We sometimes also found like this. This is hyperdensity in hypodensity in CT scan. This is intratumoral hemorrhage. And even in cortical ICH, there is still subtypes. The patient with the cortical SEH, but with associated subarachnoid hemorrhage or finger-like projection like this. So it is happened in older age, more severe ICH at onset, higher in hospital case fatality, and higher MRS score at discharge. So this kind of subtype of cortical ICH, we also have with high morbidity and mortality. So we go to etiology of ICH. Most of the ICH is due to hemodynamic factor, arterial hypertension. So this is a very typical location of hypertensive ICH, but in neurointerventional point of view, the structural fracture or malformation in the cerebral blood vessel is frequently we found. Even it is just like EVM, dural fistula, or aneurysm. So in neurointerventional practice, when we do digital subtraction angiography, we frequently found this etiology of ICH in our practice. How about SEH? SEH also there is some subtype. There is a diffuse SEH like this, probably perimesencephalic, and then sulcal SEH, and combination of SEH and ICH. So subarachnoid hemorrhage, diffuse, is mostly because of aneurysm, and the risk of the rebleeding is very high, and we have to treat in acute phase. But in another two type of SEH, cortical and perimesencephalic, mostly not because of the aneurysm. So the risk of rebleeding is quite low. This is the risk of recurrent intracerebral hemorrhage, regardless it is because of the vascular malformation or not. So the highest rate is 13.7% reported by Smith, and the lowest is 1.8. So 1.8 to 13.7% in this series. So recurrent hemorrhagic stroke, why is it happen? Sometimes we always ask our resident why it has happened, recurrent hemorrhagic stroke. Did you identify the etiology before the start or not? Did you treat the etiology or not? Why the patient is come back with recurrent hemorrhagic stroke? So recurrent hemorrhagic stroke, there are two issues, medical issue and neurointerventional or surgical issue. We can see medical issue. Hypertension is poor control of hypertension was found 46% 7% of hypertensive patient with rebleeding. So it's very high. And then age also. The annual recurrent ICH rate was higher in patient with older than younger. The location, lobar is 3 to 4 times more likely to have a recurrent bleed. Smoking, 2.6 times. And then male smoker, more than 20 cigarettes per day. Relative risk for 2 times higher. And then post-surgical evaluation, as patient came with the IC8 and perform a surgical evaluation, and the rate of rebleeding is higher in the patient with surgical than non-surgical. And in neurointerventional point of view, so related to vascular lesion, arterial, capillary, vein, and other, there is a diagnostic issue and treatment issue. So we found that the patient is under diagnosis of etiology and untreated of the malformation of vascular origin. So this is the primary hypertensive ICH. Is mostly in perforator, subcortical, small vessel. There is miliary aneurysm, microaneurysm, berry aneurysm, Charcot-Bouchet aneurysm. So this is our cases, just like this is the subcortical IC8. On angiography, we found there is a small aneurysm on lenticular striate artery. So how high is the recurrent hemorrhagic stroke? So we see that the SEH and ICH due to EVM, they have tend to recurrent hemorrhagic stroke. Rebleeding rate is different, EVM and aneurysmal. Aneurysmal is more likely to bleed, 50% in 1 year. So the second bleeding is mostly 40% in mortality. And bleed case fatality rate, it's different, EVM and aneurysm. 180% at 1 month and 50% in 1 month. But if the patient is more than 1 month, so bleeding morbidity is 30% and 30% in 1 month in aneurysmal SEH. And overall, aneurysmal SEH is more and have a higher mortality than EVM. So stroke is the problem of stroke is vascular origin. Some of our colleagues in rural area, they only have CT scan. They don't have vascular imaging. So this is the problem, the patient with recurrent hemorrhagic stroke, because they only stop in CT scan. In case of stroke, we have to identify etiology through laboratory examination, cardiac study, neurovascular imaging. So we have MRI, CT angiography, and DSA. In hemorrhagic stroke, we will find EVM, aneurysm, dural fistula, moya, and others. And in infarction with this neurovascular imaging, we will find stenosis, dissection, vasculitis, and others. And then after we identify the etiology, we have to treat this patient with neurointerventional procedure and or surgical or best medical management. So vascular imaging is very important to identify the etiology and to treat the etiology. So this is the example of CT angiography. This is CT angiography. We found the aneurysm here inside the clot. And we can use MR angiography also with contrast or without contrast. And the best modality for vascular imaging, of course, digital subtraction angiography. We can make DSA, 3D DSA like this. So actually, cerebral or spinal DSA, we can perform in our cath lab by our colleagues in interventional neurologists. In Rumah Sakit Dr. Sutomo Hospital, we have currently our dedicated cath lab machine only for neuro, and the average time is very fast. And by plane, we can finish around 20 to 30 minutes. So how is the recommendation regarding the ICH pathogenesis? We can see here, if we found spontaneous IVH or primary IVH, so we have to do digital subtraction angiography. This is class 1. Just like this patient, if we found this patient, so we have to follow with catheter angiography. And then in patient with a spontaneous ICH, we also have to suggest intraarterial DSA if in CT and MRI we don't find any finding, but we suspected macrovascular causes. So we have to continue with DSA. So the recommendation also class 1. And there is some condition when we have to do CT angiography, MR angiography, or DSA. Lobar, age, and then hypertensive or not. Actually, this all is already covered in SICH score. I will mention after. And then in patient with ICH, but with negative catheter DSA, but we still suspected vascular malformation, we have to repeat DSA. So this is the to be a recommendation. So this is our patient, male, 50 years old, with acute decrease of consciousness, vomiting, and general onset seizure. So this is intraventricular hemorrhage. There is no other source of bleeding except intraventricular hemorrhage. And what happened is, when we perform CT angiography and DSA, we found there is EVM, and some of EVM is coming in the top of the ventricle. So the bleeding source is periventricular. So when we identify this lesion and we know the etiology, we treat this with embolization. We perform targeted embolization. We occlude this nidus that bleed, and this is after. So after we occlude this with targeted embolization, we put back the patient come to the natural history of EVM. What is SICH score? Secondary intracerebral hemorrhagic score to determine structural vascular etiology, high sensitivity and specificity. Very helpful to determine which case should be referred to vascular imaging, CTA, MRI, DSA. So this is the sensitivity. So if the score is 3, the vascular malformation will found with 18%. If it is 6, so 100% will be found vascular malformation. It's already validated, and this is the score from the non-contrast CT, from the age, from the sex, and the is there any hypertension or not. This is the etiology already found in this series of study: EVM, aneurysm, dural fistula, arteriovenous fistula, moya-moya, vasculopathy, and others. So this is our patient, girl, 7 years old, suddenly unconscious 3 hours before admitted. No hypertension. It's very less than 45. So the SIH score is 5. So we can see from here, we can identify the micro AVM here. The AVM is inside the clot here. So SICH score is quite sensitive in our daily practice in Surabaya. In case we found hemorrhagic stroke with on-the-head CT scan non-contrast, it can be SEH or ICH. In case of SEH, we perform CT angiography if we have in our emergency room. If it is pro-vascular malformation, so neurointerventional procedure will be performed here. But if it is not, medical management. But in case diffuse SEH, we don't find any vascular malformation, we continue with digital subtraction angiography. How about ICH? ICH, we use as ICH score in emergency room. And if it is more than 3 or more, so we continue with CT angiography. Otherwise, we go for DSA directly. So this is our protocol. How about SEH? Aneurysmal or aneurysmal? So rebleeding in aneurysmal subarachnoid hemorrhage is the most preventable serious complication of ASEH. So our mortality in our hospital is decreased continuously when we have very good service of interventional neurology. And now we have a dedicated neurocath lab. So the treatment of aneurysm is even faster in 1 or 2 or 3 days after ictus. The meta-analysis of 14 studies, including more than 5,000 patients, the recurrent rebleeding in aneurysmal subarachnoid hemorrhage is 7 to 26%. So this is subtype of IAS I already mentioned. The diffuse type is aneurysmal type, and the chance of rebleeding is very high in this patient. But another type, sulcal or convexal and perimesencephalic, mostly they are because of the venous bleeding or amyloid angiopathy and less risk of rebleeding compared with diffuse type. So this is diffuse type is the typical type of aneurysm. In some cases, no aneurysm was found after vascular imaging because sensitivity of vascular imaging is different. MRA, CT angiography, 3D-DSA. It means that if we didn't find aneurysm after vascular imaging, it doesn't mean there is no aneurysm. Why aneurysm is not depicted on first angiography? It's probably very small aneurysm, less than 3 millimeter in CTA. Sometimes it's covered by bone, we cannot see it. Even in some patients with less than 1 millimeter. Small aneurysm with intraluminal thrombus, aneurysm on arterial dissection, suboptimal image quality due to technical reason in CT angiography or MR angiography, misdiagnosis of aneurysm, and SEH from spinal vascular malformation. We found in several cases SEH is not from cerebral vessel, but it is coming from a spinal vessel. If we don't evaluate spinal vessel, so we will conclude that the patient is non-aneurysmal, but it is wrong because we have to go to spinal in case of diffuse SEH. So when clinically suspected SEH, we perform non-contrast CT scan. We can identify from non-contrast CT scan whether this is diffuse, perimesencephalic, sulcar, or negative SEH. In case of diffuse SEH, we have to perform CT angiography. If aneurysm is negative, so we have to go to 3D-DSA. But if aneurysm is positive, so we have to go to surgical endovascular. Sometimes, if CT angiography not available in emergency room, we have directly going to do 3D-DSA. So in our cases in Dr. Sutomo Hospital, most of the patient with SEH is going to cath lab, and then if we found the aneurysm, directly we perform coiling in the same time. But if it is perimesencephalic, sulcan SEH, we perform CT angiography, and then we do not need to repeat DSA. If it is negative, so medical treatment. We do not need to repeat. It is different with diffuse SEH. If it is negative, we will repeat 3 to 6 months after. So, is repeat DSA really needed in initial negative finding of diffuse SEH? So this is the study, almost 300 patients, and 30 patients aneurysm negative on angiography. And repeat angiography found 26.7% aneurysm positive after negative finding. So it is quite high. 1 out of 4 patients will have positive aneurysm after negative finding. And this is correlated with rebleeding rate if it is missed. Again, our cases, male 27 years old with severe HEJ, with SEH subtype. Of course, this type of SEH is a diffuse aneurysmal SEH. It is not sulcal, it is also not perimesencephalic. So high probability of aneurysm. But what happened is, in CT angiography, the radiologist reported there is no aneurysm here. But after DSA, we found there is aneurysm on SCA. We selectively catheterize. Here is the aneurysm, and we occlude this one with glue. So the rate of recurrent bleeding is near 0. Okay. And the second case is male 20 years old. Again, from CT angiography, found as normal. So if we stop here, the patient will come back with rebleeding. This is after 3D DSA, we found there is dissecting aneurysm in peripheral vessel. And then again, we only occlude with a drop of glue in this patient. This is before and this is after. So we glue this aneurysm. Again, a female, 50 years old. Patient hospitalized with SEH. Because at the time 2050, we have to wait for the cath lab because we share our cath lab with the cardiologist, so we cannot perform very fast for the interventional procedure. We're waiting for that. We're waiting for that queue. So the patient is rebleeding after 2 weeks inside the hospital, and then again rebleeding after 1 week. So during hospitalized, the patient have 2 times of bleeding. So this patient with 3 times of bleeding. And we perform CT angiography, we found this aneurysm on ACOM. And then finally we perform coiling. We can see this is the coil on the ACOM aneurysm. So from meta-analysis, rebleeding rate is very high, even during hospitalization, 7% to 26%. How about the rate of rebleeding? The patient is already treated with coiling and clipping, but why the patient is still have a recurrent hemorrhagic stroke? The risk is different, indicate that need to treat 50 patients in the surgical arm compared with endovascular. So clipping from the evidence said that clipping is more stable and the risk of bleeding is less than endovascular. But in endovascular, the risk of poor functional outcome is less than clipping. So endovascular intervention result in lower chance of dependency compared with surgical for repair of rupture anterior circulation aneurysm. This is probably the cause why coiling have recurrent bleed is more than the clipping, because different packing of the aneurysm. This is the example. First time in compact coiling, but after 6 months, it regrowth on the neck and then bleed after 8 months. This is also in PCOM. We can see after 6 months, it's regrowth and again rebleed after 7 months. Another case, the patient with previously coiled can be ruptured after. So the follow-up of the DS is very important in patient with it's already performed coil. This is our case. I think this is a very interesting case. We already reported actually. This case report is a rare case of spontaneous thrombosis in saccular cerebral aneurysm. This patient came with subarachnoid hemorrhage, and on CT angiography, we found MCA aneurysm, but after 1 month, the aneurysm is disappear. It's because of spontaneous thrombosis. And we follow up 1 year. This is 2020, this is 2021. We follow up 1 year, it's still stable. There is no aneurysm. But what happened is after 4 years, the patient come with intracerebral cerebral and subdural hemorrhage. We can see here. After 4 years, and the patient is going for surgery, and again the aneurysm is coming, and then we occlude with the coiling. So even the patient with spontaneous regression or spontaneous occlusion of aneurysm can be again recanalized after 4 years in our case. Another case is girl, 7 years old, unconscious, left hemiplegia. This is anterior view, this is posterior view, there is no aneurysm here. But in 3D DSA, we found micro EVM here. So the sensitivity of imaging, vascular imaging, is very important to determine whether there is vascular malformation or not. If ICH score is more than 3, we have to search the etiology. Even in CTA or MRI, there is no malformation. We have to go for 3D DSA like this patient. This is another case, a boy, sudden unconscious, 3 hours before admission. This patient is already first and second attack of ICH. 2007 evacuated, 2011 it is diagnosed as dural arteriovenous fistula. This patient is decompressive. Perform surgery, and at the time diagnosed as dural fistula. But what happened after this time? The patient came back with third attack 1 year after resection. How come the resection or the occlusion of dural fistula still have this kind of bleeding? And after the SA, we found that there is not a dural fistula. This is the EVM. So, performing surgery based only on CT angiography is sometimes missing of diagnosis. That one is the first time diagnosed as dural fistula, but now from the DSA we found very clearly this is EVM. Identification etiology of ICH before discharge is very important. Best and prompt treatment modality is also very important. How about the rebleeding after brain arteriovenous malformation? Recurrent hemorrhage is major concern of brain arteriovenous malformation. Past hemorrhage is the single most important risk factor of brain AVM rupture. It has been suggested that the rate of recurrent is more important in the first year following brain BAVM rupture. And only complete BAVM obliteration is protect against rebleeding. It is contrary to aneurysm subarachnoid hemorrhage, where aneurysm treatment at the acute phase is the norm. So we have to treat aneurysm as soon as possible. But in brain AVM, few authors advocated early BAVM endovascular or surgical obliteration after rupture because there is still edema and probably nidus still hiding in the edema or in the hemorrhage site. So this is our cases, male 25 years old with left occipital. This is ICH second attack actually, this patient. It already decompressed and evacuated. We can see this is EVM, and we found there are some weakest point. There is aneurysm inside the nidus. There is 2 aneurysm. First, we treat with glue, and the second, we treat with coil. And the last one, we treat with liquid embolic agent. So this is before and this is after. So we have stage embolization with this patient. First, we perform targeted embolization, and the last one, we try to obliterate the AVM. This is another example of a female 43 years old with IVH and ICH. We can see there is calcification here with high SICH score. I think SICH score is 6, 100% is vascular malformation. This is the quite big EVM. We perform first targeted embolization. You can see we injected glue here. This is first embolization, and then this is the second step embolization. We injected glue. This is the glue is coming down. After second step embolization, the AVM is reducing here. So what happened is after 3 years, again another bleeding, and we perform third embolization. Again, we cannot completely remove all EVM from circulation because this is a quite big EVM. After third step embolization. So factor related to recurrent hemorrhagic stroke is first is problem on diagnostic modality, limitation or diagnostic tool. Probably we don't have a very good CT angiography or with lower Tesla of MRI. Facial imaging MRI without contrast is less than CTA and less than 3D DSA. Sometimes we stop in this vascular imaging, we don't continue to DSA, 3D DSA. Intrathecal variability of X minor. Sometimes we need a very good neuroradiologist to found this vascular malformation. Limitation on treatment access. In some of the region in Indonesia, we don't have a good treatment access. Sometimes they treat only medical management and they can refer to a referral center. So unavailable treatment of option, just like gamma knife, very limited gamma knife only in Jakarta. And neurointerventional device, sometimes it is expensive, it is unaffordable by the patient. Loss of follow-up after discharge. This is also chance of the recurrent hemorrhagic stroke is high. I already showed how the aneurysm is regrown. And natural history of neurovascular disease and dilemmatic treatment options. Sometimes antiplatelet is needed in patient with intracranial atherosclerotic, but the patient also have a history of ICH. Antiplatelet in unruptured aneurysm or cavernoma or EVM. So this is another case of patient with this is first attack, this is third attack, female 38 years old. This patient is not followed previously by vascular imaging, only treat medically. But when we perform CT angiography after third attack, again there is no vascular malformation. It is normal finding. What happens is when we perform MRI, there is a pocketed sinusoid here, and this is cavernoma. And the gold standard of cavernoma is MRI, not CT angiography. Even sometimes we found it is normal DSA, even with 3D. We can see here. So cavernoma, it is mostly isolated, and when we perform CT angiography or DSA, the contrast is not filling this. So the gold standard is MRI, and the only modality of treatment is surgical. This is after surgery. We can see here. Cavernous angioma or cavernoma, the risk of bleeding is 6.3% per year if the lesion is non-brainstem, but in brainstem it is higher, 32.3 per year if the lesion is on brainstem. So the conclusion of my presentation is that recurrent hemorrhagic stroke is common and could be a devastating condition. It's related to medical and neurointerventional or surgical issue. Neurointerventional issue mostly in diagnostic because less patient is doing vascular imaging, MRI, CT angiography, DSA, and also sometimes prompt treatment is needed. So even the patient after treatment, there is a chance of recurrent hemorrhagic stroke. Treating the risk factor and etiology before after discharge is important to prevent further event. So this is last cases. Just male 42 years old. How is the SICH score? We can see there is a bleeding in thalamus. This is high probability because we have seen there is venous attenuation in brainstem, in another area, and remote of the bleeding. There is a venous attenuation, so the score is 2, and non-hypertensive is 1, female is 1, age is less than 45, so the score is 5. Score is 5, probability of vascular imaging is 84%. And this is from MRI. We can see there is a massive dural fistula. Here, massive dural fistula. From external carotid artery. Right side, and this is from left side also. From internal carotid also. From posterior circulation also. All the vessel is going to the vein, and this is a very massive dural fistula. And we have to choose the embolization device, and also which embolic agent is proper for this patient. So we occlude with a squid in this patient. Okay, so just some information. This is distribution of neurointerventionists in Indonesia, interventional neurologists. 2014 we have 20, and currently we have almost 100. And the number of neurointerventionists in Indonesia is decreased very significantly, because currently we have our fellowship program in Indonesia, and our government now is want increasing number, because they give many cath lab and all region in Indonesia. This is our group. Thank you very much for your attention. Dr. Kumara, thank you.
Yeah. Thank you, Dr. Firdaus, for your very nice and informative information on the cause of underlying vascular malformation as the cause or the etiology of intracerebral or subarachnoid hemorrhage. So we can see from your presentation there are several causes of ACH or SAH produced by underlying vascular malformation, and I believe this kind of becoming more and more revealed was there is an advantage in advance in the diagnostic use. So this is quite helpful for us. Before we move to question and answer session, on behalf of everyone here and neurologists from ASNA, from Indonesia and Asia, also Malaysia, I'd like to thank you, Prof. Lim Keng Xiang from ASNA, from providing us this webinar. So thank you so much. So this is quite helpful to gather us together before the real ASNA in Bali in probably August 2025. So the participant can ask your questions by write down your questions by click on the chat image at the bottom right of your screen, or you may directly ask by raise your hand. I think there is one question already here from Indonesia, from Rifan Danwaji. So this question is sorry. Thank you for your good talk, Dr. Firdaus. And then Dr. Rifan have one question. His question is, which one is more dangerous between recurrent bleeding or the vasospasm in subarachnoid hemorrhage in the first week of the ACH? And is there any option for neurointervention for to cure patient with vasospasm?
Thank you, Dr. Kumara. Thank you, Dr. Irfan. So, which one is more dangerous? More devastating is, of course, rebleeding. In the first week, the chance, the rate of rebleeding in SEH with aneurysm is 50%, and the mortality is 40% in 1 week. But vasospasm, it is also bad for us, because vasospasm will be cause delayed cerebral ischemia. But when the patient is came in the first week, and then we treat with coiling, and we can find there is a vasospasm in several vessels, we can inject nimodipine intraarterially during our procedure, and it is very helpful. And for several minutes, we can see the difference between before and after. And then we can continue after coiling with intravenous or oral nimodipine. So rebleeding is mostly happen, and in some cases it's happen even before the patient is going to the table of the cath lab, and it can be happen also on the cath lab. So rebleeding is very devastating. Thank you.
Any questions from the audience? Okay. I have one question, Dr. Firdaus. We know that cerebral venous thrombosis is quite frequent in Indonesia, especially in the certain part of Indonesia. Bali also, I myself from Bali, so Bali also have quite a high incidence of cerebral venous thrombosis, which is presented as a hemorrhage. And sometimes in the very grave situation, the patient needs like a very aggressive treatment, such as intravenous thrombolysis or mechanical thrombectomy, something like that, to just to help the patient out from that grave prognosis. We have to do something like very aggressive, sometimes we need neurointervention, sometimes we need like heparinization for up to 5 days, so the patient can survive. So how we can so in the terms of intracerebral hemorrhage, how we can suspect that this is probably the cause is the underlying cerebral venous thrombosis, which can turn back the fate of this patient if we can promptly treat this patient. I cannot hear your voice, maybe something.
Sorry. Yes, thank you, Dr. Kumar. It's a very important question. We frequently found the bleeding is uncommon bleeding. It is not subcortical, it is not cortical like before, but sometimes the bleeding is on venous territory, and sometimes there is edema. So, in case of this kind of patient, we have to perform MR venography, and unfortunately, some center there is only perform CT angiography or MR angiography, not CT venography or MR venography. So we cannot see the site of the thrombosis. Most of the thrombosis is in superior sagittal sinus, and it can be 1/3 anterior or 1/3 middle or 1/3 posterior. So 1/3 anterior have quite more good prognosis than the middle or posterior. So in this case, actually we have to be very aggressive to give anticoagulation, to anticoagulate the patient. Some doctor probably is reluctant or afraid to give anticoagulant in patient with intracerebral hemorrhage. But if the etiology is very, very clear, this is from vein thrombosis, so we have to give anticoagulation, and the prognosis is quite good for this patient. In some center of neurointervention, they will perform a thrombolysis. They can go intravenously and going to the thrombus, and until now there is no time window, strict time window. How long is, just like our IV thrombolysis of thrombectomy, we have time, but in cerebral venous thrombosis there is still not cutting which time is the best to do this. Some doctor give anticoagulation and they evaluate. If it is failed, sometimes there is go intravenously. Okay, probably this answer your question, Dr. Kumara.
Yes, thank you. And I move on. There is 2 questions shown on this chat. Second question is from Novelin Sagita. Her question is, can you tell us the dose of nimodipine intraarterial if you give them for vasospasm during coiling procedure? So yes. It is a complication of the coiling procedures. No complication. How we can go through that vasospasm if we want to do coiling procedures? I think that's the questions.
Yes, thank you, Dr. Kumara. Thank you, Dr. Novelin. So sometimes before we perform coiling, the excess of the catheter cannot enter the aneurysm because of severe vasospasm. At the time, we injected intraarterially inside the artery, so the vessel will open, and then we go through the vessel and going to the aneurysm. And the dose is 5 milligram per vessel. 5 milligram per vessel. If there is right ICA, right MCA, we injected 5 milligram. If it is in anterior cerebral artery, we also injected 5 milligram. But most of our experience, 1 milligram is enough. 1 milligram injection with PZ. We dilute with PZ, and then we injected 1 milligram. Is sometimes already open the vessel. I think that's the question. Yes.
Yes. We still have time, right, Professor Lim? Yeah.
Yes, we have. Yeah, another 8 minutes.
Okay. I think this is probably last question from Richard Suherlim. His question is regarding subarachnoid hemorrhage. If the patient is worsening in 3 up to 10 days without new rebleeding, and we found severe vasospasm on TCD despite this patient has been given oral or IV nimodipine, is that an indication for doing intraarterial nimodipine in the cath lab?
Thank you, Dr. Kumara. Thank you, Dr. Richard. Yes. It is very important to perform transcranial Doppler to evaluate the patient day by day. And every morning we have to perform them actually by a resident or by the fellow to ensure that there is no vasospasm. If the patient is decrease of consciousness, we have to examine the patient whether, first, is there any rebleeding? The second one, is there any hydrocephalus? Hydrocephalus due to subarachnoid hemorrhage is very, very frequent. Hydrocephalus is coming subacutely after 3 days. And the third one is there any delayed cerebral ischemia? If it is suspected vasospasm, and we already have IV or oral nimodipine, it doesn't help. Of course, we have to evaluate, and we have to go to the cath lab, and we injected nimodipine intra-arterially. And a lot of cases will be improved after injection of the intra-arterial nimodipine. And it is very helpful for the patient. So transcranial Doppler is very important to evaluate day by day for the patient with subarachnoid hemorrhage. Yes, thank you.
I've seen no question on the screen. If we still have time, I will ask you one question, Dr. Firdaus. So based on your presentation, we see that there is certain type of ICH that we suspect the cause of the bleeding is primarily because of the chronic hypertension, such as subcortical or basal ganglia or cerebellar or pons. And then you combine with secondary ICH score. How to define that this patient is primarily or secondary. But sometimes in certain cases, we find that with an exception. Surprisingly, that the cause of the bleeding, the underlying cause is vascular malformation such as AVM in the cerebellum. Although the patient is older age and have high blood pressure. So in this case, I found myself this kind of situation, and then after I perform MRI, and then I've seen no sign of chronic hypertension in this patient. So I decided to do a DSA, and then we found that the cause of the bleeding is a cerebellar AVM. So do you think with this type of the location of the ICH, and then we combine with the ICH score, do you think that we still need to do like at least MRI to find out there is a trace of chronic hypertension or something, or we just what do you think? You are still mute.
Thank you, Dr. Kumara, for the question. Dr. Kumara is also interventional neurologist, so he had also a lot of patients in Bali. So in our daily practice, actually stroke, the problem of stroke is on the vascular. So ideally, in my humble opinion, we have to perform vascular imaging and all type of stroke actually, if we know that the problem is a vessel. But in some cases, there is high probability of vascular etiology. There is low probability of vascular etiology. So that's why they make a SIH score. So I think this is helpful for us to screen, to make a screening the patient, which one should go to vascular imaging, which one is not. So in our developing countries, so this is also will saving cost. But in case of there is probability of vascular imaging, just like hypertension. There is exceptional cases that it's look like hypertensive, but there is vascular malformation. Just like what Dr. Kumara said, that there is no a sign of hypertensive. We can go for vascular imaging also. So the score actually just guide us, help us which one should be go vascular malformation. Even the chance of less than 10% of ICH score, we found there is a vascular malformation in some patient. So the most important one is, according to me, that stroke. The problem of stroke is the vessel, and doing vascular imaging is very important in every patient of stroke. Even in ischemic stroke, the patient with low and IS score is look like a small vessel, but can be a large vessel occlusion. So yeah, that's I think you have your own opinion, Dr. Kumara.
Yes, I think I will do more advanced investigation imaging in every case of patients, unless this patient is proven that the patient has a chronic hypertension. Prof. Lim, any comment?
Thank you so much for. Sorry, maybe I mute Dr. Fadal's mic because there's echo. Thank you so much for sharing today, and it's very amazing to see the number of interventionists in Indonesia, which is almost 100, is much more many than many other countries in the regions. And it's also great to see the success in many of the cases that you have presented. And I think this is a good teaching point to all of us, especially for recurrent bleed. And thank you again for Dr. Kumaras to chair these sessions. Looking forward to see you in Bali.
Yes.
soon. And thank you, Paulos, for organizing this. Thank you, everyone, for joining.
Thank you, Prof. Lim.
Thank you, Prof. Lim.
Prof. Lim is current president of Asian Neurology Association. So it's very, I'm very happy to meet you here, although we are in a webinar. So I will meet you in person soon in Bali. So I think the time is over. And yeah. So the conclusion is now there is a growing number of vascular malformation as the underlying cause of many types of in the brain. So we have many kind of tools, start from the anamnesis for physical examination, from the plain CT, and then we have SCORE also. So this webinar help us to broaden our knowledge that there are several vascular underlying malformation that can cause recurrent bleeding or recurrent stroke in the patient, which can have a devastating prognosis. So I hope you enjoy all these webinar, and then I hope this webinar also benefit you all. So to me, I will close this webinar on behalf of Prof. Lim. So see you in ASNA in August 2025, probably in August 2025. See you all.
See you. Thank you. Thank you, everyone.
Yeah, thank you everyone. Thank you, Prof. Lim.
Thank you, Prof. Lim. Thank you, Dr. Paulus, Dr. Kumara.
Thank you, Firdaus, Kumara.
Yes.